Welcome, everybody, to the latest episode of the Interventional Endoscopist podcast. I'm your host, Mankal Satdev, and today, on this very special episode, which is episode number 30, I started this podcast about almost 2 years ago, and now we're at 30 episodes, which is really great. Something that started out as a hobby and continues to remain a hobby, and just a great way to meet people and engage with people has just become a real fun pastime for me. So today we have the pleasure of revisiting with Dr. Toufic Kachaamy. He was our guest on episode number 4. So Toufic, welcome.
Oh, thank you, Mike. It's really a pleasure to join you and to see your podcast growing and becoming very popular.
Thanks. Thank you. Now, speaking of growth, one of the reasons that we're here today is and we'll get to it in a few moments, is we're going to talk about this course that you have now done for, I think, 3, maybe 4 years now.
4 years, yes.
4 years. So this is year number 4 of the course, and we'll get to that in a moment. My normal format for most podcasts is we talk about the background of everyone, but we spent a lot of time on that with you in episode 4. But it's just a brief reminder. You are currently the chief of GI and chief of medicine, if I'm not mistaken, at the City of Hope campus in Phoenix, Arizona, correct?
Yes.
All right. And you're also involved with the ASGE, with the Endoscopic Oncology SIG. You're the founder of that. Tell me a little bit about that and how that's been growing over the last 3 to 4 years since you started it.
It's been going great. It's been a very nice journey. We just had one of our webinars in January, and we had 180 people, 184 people who were registered for the webinar, compared to our first one, which we had 12 people, 2 years ago.
That's Kovacs. Actually, more than that. My mom's it's 14x maybe.
So it's been really nice. It's a field that we continue to define. A field that's still not finding its real niche, but it's a field that is growing not just in interest and really real applications.
So for those listeners who might not be familiar, kind of give me an overview of what is endoscopic oncology, number one, and why is it important?
Yeah, so endoscopic oncology is the field of taking care of cancer patients with endoscopy. And as of now, it is focused on gastroenterology. Gastroenterology is the discipline that has the most tools in endoscopy today. 1, because of volume, 2, because of the size of the scope. There are many reasons why I think gastroenterology needs the world of endoscopy. But taking care of cancer patients require a different level of cognitive skills and technical skills, and requires understanding of the cancer field in terms of diagnosis, prognosis, staging. Is an entire field by itself that today there's really no training for. And I think the closest training to it is interventional endoscopy. Interventional endoscopy tends to gear more towards the cancer because a lot of the interventions are done in cancer patients. But unless you understand cancer biology, cancer treatments, which are rapidly evolving, it's hard to determine if your intervention is appropriate and is going to help the patient.
Yeah. Now that makes a lot of sense. I think, we all, when we do interventional endoscopy fellowships and training, we definitely learn how to do these procedures, and, we're taught when to use them and when not to. But afterwards, I think, a lot of the innovation requires in thinking outside of the box, especially in our field. And I think without having those conversations and learning more about these techniques in certain scenarios, it becomes difficult to decide when to use them and when not to use them. And I think something like a discipline of endoscopic oncology helps us use those skills to kind of treat patients better, and then also incorporate them into tumor boards and discussions with other physicians, so that people know, hey, we're not just crazy cowboys sitting out here and trying to do this, and also reminding ourselves, just because we know how to do something, because we know how to do a full thickness resection or a ESD or something along those lines, doesn't always mean that we should do it, and so I think those are um learning when to use your tools, how to use them, and then defining it. That's the most important thing, because we don't have guidance out there in the community at the moment.
Absolutely. And learning to be a team member, because cancer care is a team sport,
Yeah.
is very important. We are kind of the leaders in the endoscopy unit. But the medical oncologist is the leader in the cancer care, and understanding that you serve two gods, the patients and the medical oncologist who is trying to serve the patient. So it's not about doing what you think needs to be done. It's about doing what the group thinks needs to be done.
Yeah. Yeah. And also, I think you helped to start the endoscopic oncology division of Fight as well. And how's that one going?
That's the same. I mean, the entire field, I think, is growing so fast. And, I'm the chair for the endoscopic oncology committee in Fight. And that has been a really nice journey, getting some people together focused on this field, talking. Our first article that will come out is to define endoscopic oncology. So you'll see some work coming from that committee.
Right. And that'll be a white paper, and I'm not sure where they're going to publish it, but that'll be great to see when it comes out and actually start that discussion. And I'm curious, one thing we talked about in episode 4 was we talked about and I've talked about it frequently with you as well as others, is that when you get into interventional endoscopy, I see a future where you'll subspecialize, whether you're an endobariatrician or a biliary doctor, or you might be an endoscopic oncologist. Have you started to see any programs offer kind of more focused training on endoscopic oncology, or maybe kind of certain programs around the country that are geared towards that?
Yeah, that term was actually coined at the Moffitt Cancer Center, and they were the only place that had an endoscopic oncology kind of type of training. But no, I have not seen a program focus on that. I think an entire year dedicated to that would be great. But given the challenges in adding an extra year to an extra year of training, I see more of a 3 months uh, plan where people get introduced to how to incorporate
Right.
endoscopic oncology, and then have the skills to continue that journey, because the field of cancer is probably the most rapidly changing cancer field in medicine, and I don't think training by itself will be enough. You have to learn how to keep up with the field.
Yeah. No, I think that's actually great. I mean, because the tools to do the procedures you learn in your interventional year, and then, obviously, depending on what the strengths of that program are, you might learn more, X, which is Y. But then spending a few months kind of learning how to incorporate it, as you mentioned, working with oncology teams, multi-D teams, those type of things. I think that's where the benefit will happen, because you already know the procedures for the most part. Uh, Maybe some programs do more tissue resection than ablations, or something along those lines, and vice versa. But you learn the skills of the basics, and I think just applying them and then spending a few months learning the flow and learning how you fit into the world of oncology. Also, I think it would be important that any fellow that's going to go there really knows that they're going to be in a work environment that allows them to use it. You don't want to be, I mean, for example, me, I'm in private practice, interventional / general GI, and while I have some of the tools to do the endoscopic oncology procedures, I'm not involved in a tumor board or an oncology or cancer center or something like that. So I'm not, every patient of mine is not cancer, and I think in your environment, a majority of your patients are cancer, and so it behooves the person going into it to know that that's the world that they're going to dedicate their careers to afterwards.
It's a very rewarding career, I can tell you that. I've been doing it now for 13 years.
Wow. Yep. This is about as long as I've known you, for almost 14. Yeah, getting old, man. Okay.
Older.
We're not much wiser in my situation. Um,
Very pleasure here.
so let's kind of get into the course. Let's first talk about the history of it, because as you probably know, I like to talk about how things come to fruition. So kind of rewind us back to about 4 or 5 years ago, maybe 6 years ago, when you started thinking about this. How did you get it done? Where was the first one? Kind of let's start from there. I'll give you the floor.
Yeah, the inception of the course actually, at least in my mind, started when I started going to GI ASCO for, gastroenterologists who are not in the cancer world. ASCO is the American Society of Clinical Oncology, and it's kind of the big, it's like ACC for cardiology. And it's a combination probably of ACG, ASG, and AGA for gastroenterology. They put a course together that is GI oncology focus called GI ASCO. It's in San Francisco every year, and I think this year was like year number 9 that I go to it. And when I go there, I almost see no gastroenterologists there, and it's majority focused on medical oncology. So even there are a few surgeons for radiation oncologists. And as I started looking around to see if there's a course that is less focused on systemic therapy and more focused on multidisciplinary care, I could not find one. So I decided, you know, I'm going to create one, which is a focus that is heavy in oncology, but also gears towards bridging the gap between gastroenterology and oncology. Oncologists are not educated on what we do, and we're not educated on what they do. So what's unique about this course is it basically bridges the gap. It's very focused on the area of overlap. If you look, for example, I'm going to give you an example that most gastroenterologists who practice therapeutic endoscopy are familiar with. When you place a colonic stent, do you increase the risk of perforation or not? That's an area where probably endoscopic oncology is heavily applicable. But that's an area where what we do in the lab in half an hour impacts the course of the patient over time, and that decision has to be made as a group. So these discussions are not done in any other course. So we started the course and we brought people in and started that discussion. It started very small, very intimate, and it's been grown since then. But it's basically focused on the areas of overlap where we need to have a discussion, but there's no other forum for these discussions.
No, that's great. I mean, if sometimes it's really hard to work through bureaucracies of societies, as we all know. And that's not an insult. That's just the truth of it. There's so many people involved that, sometimes to add something to a course of the size of ASCO or ASCO GI is going to be difficult. And in a way, it's better to make it your own, because honestly, they create that course, or they create maybe what do they call a track for endoscopic oncology. You're the only GI going to that. It's not really going to attract 3 or 4, but maybe it attracts 3 or 4 more. It won't attract a whole bunch of people to do that course at their San Francisco meeting. So when you create it in a separate environment, it's actually good, because now you can focus it towards the people who need to be involved in that, interest.
Exactly.
Okay, so your first one was your first 3 courses were here in the Phoenix area. Talk about kind of enrollment as time has gone on.
Yeah, so I think we started with 50 people on the first course, and we were up to 120 last year, and are hoping to blow past that. I do not have intentions to make this course very large, because it's actually more about the discussions between the expert we bring together. So I think of it more as a show. What we are hoping to achieve also today is throughout the year, put learning points from the course to educate people throughout the year, not just during these 2 days of intensive course.
Yeah.
The goal of that course is not to be thousands. It's to continue to be on an intimate group that are kind of discussing very, very focused topics that overlap.
Right, right. And so this year's course is a little bit different in the sense that it's not in Phoenix any longer. You kind of put it in a place that a lot of people enjoy going to. I'll let you talk about where it is and where it's hosted at.
Yeah, so we're trying this year to move to Las Vegas. We're going to be at the Waldorf Astoria in the middle of.
Fancy schmancy.
Yeah, I have that reputation of being a diva, um, and we're trying to go national and attract a larger audience.
Yeah.
And try to continue to keep the intimate feel for the course, but at the same time try to reach a broader audience on the journey of being international. We have one international faculty this year
Oh wow. Well, who's that?
from Canada.
Okay.
His name is Jordan, and he is going to be talking to us about the application of genomic testing, specifically multi-cancer early detection in lower resource settings.
Oh wow. Okay. And that's Jordan Yanuzzi or Ayanuzzi, I think.
Correct.
Yeah. Okay. Good. That's awesome. So, and he's an oncologist or an endoscopist?
He is a gastroenterologist focused on genomics.
Awesome.
Cancer there, yeah.
Okay. Okay. So that, yeah. So, and the course, we forgot to mention is going to be April 5th, of this year. So you've got about 2 more months to, uh, get set up and get in there and everything like that. And so let's talk a little bit about the course itself, the setup of it, and that. So I have the agenda pulled up here, and in the comments section or the summary, I'll make sure to put the link for anybody who might be interested in checking it out and potentially coming. But you have also for the people watching this on YouTube, periodically throughout the course, you'll see instead of my face or Toufic's, you'll see the brochure for the course. So, but you have an early start in Vegas. So, if you're a Vegas party animal like I can be, tone it down a little bit because it starts around 7 a.m. For breakfast, which is great because I'm sure there's gonna be lots of eggs and bacon for those people who are having a good time. Uh, but the first session actually starts at 8 a.m. And that one is, and I'm going to read the name of it because it's a little lengthy for me, but it's Unlocking the Secrets of Early Cancer Detection, Cutting Edge Strategies for the Next Frontier in Pancreatic Biliary Oncology. That's going to be moderated by Dr. Jules Samadar here from Mayo Clinic Scottsdale. He's he's a contemporary of ours. I think he did his interventional year, I think either the same year as me or 1 year ahead of me. I met him at many of the fellows courses when we were first running around trade, looking for opportunities and things like that. But we have four discussions during that session and a panel discussion. So tell me a little bit about that one.
Yeah, so if you look at the session, it's like all our sessions. It's very diverse, and that's something I'm very proud of in the course. Stephen Gruber is a big researcher in cancer genomics. He is an oncologist from City of Hope in Duarte. And then Christian Tomasetti is a mathematician from PGen who specializes in cancer detection and genomics.
Wow.
And then, Michelle Anderson does not need any introduction, but she will be talking about cancer detection with endoscopy, specifically focused on pancreatic biliary. And then Jordan Ayanuzzi, like I told you, will be talking about application of these expensive technologies and expensive techniques in settings that have less resources. And this is typical of our sessions. So it's I don't know of many courses that have a mathematician as part of their faculty, but because artificial intelligence, which requires a lot of algorithms and math, is a big part of the multi-cancer early detection.
Absolutely. No, I mean that's actually when you said that I was I didn't realize I saw PhD, but I had assumed that he was, just somebody in cancer markers or biology or something along those lines. And mathematician is actually amazing. So that's awesome.
And that's kind of the theme that I want throughout the course is, when people come to the course, I want them to see something that is different. I also want them to understand the importance of crossing disciplines. I always say Superman is not strong on Krypton, it's strong on Earth. So really what you bring as a gastroenterologist, for example, to the cancer world, is very powerful because it's a different point of view that oncologists do not necessarily think about. So this course is all about crossing discipline and learning from other disciplines. This is how we drive innovation, which is in the title of the course.
No, I mean, sometimes, I imagine that some of the greatest innovations in endoscopy happen when a non-endoscopist just asks a very simple question, like, well, why can't you do this? And then the interventionist says, well, we can if we did this and this. Yeah. So I mean, I'm sure that's how, when you're in a vacuum and it's just all the, same-minded people sitting in one room talking about the same thing, you all think similarly and have similar approaches. You add somebody who's completely different focus, and that just drives a whole different conversation. Session two on that day is going to be United Front Multidisciplinary Strategies for Conquering Colorectal Liver Metastasis. And that's going to be moderated by Dr. Marwan Faqih. And your speakers are going to be Dr. Gagandeep Singh, Maruf Hotape, and Jonathan Kessler. So tell me about that one.
Yeah, so in this session, we have a medical oncologist, we have a surgical oncologist, we have a hepatologist, and we have interventional radiology. Again, following the theme. Unfortunately, colorectal cancer is becoming more and more common in young adults. And because we don't screen in these folks, they often present in stage 4. And when they present in stage 4 and they're so young, one they are able to tolerate more aggressive treatment, whether that's good for them or not, is to be determined. But two, we are trying to throw the kitchen sink at these folks to try to get them cured. And I think that the best way to do that is in a very multidisciplinary fashion. And often they have what we call oligometastases, which are few metastases to the liver. And these are tackled by, IR, by medical oncology, surgical oncology. And we have a hepatologist who specializes, he's the director of liver transplant at UPenn. Because it might not be known to everyone, but chemotherapy causes fatty liver and impacts the liver. And then when you're doing surgery and resecting a part of the liver, one of the problems is the liver failure that could happen. And fatty liver contributes to liver failure. So this is an area where it is actually ripe for innovation. We now have drugs that can impact fatty liver, but these drugs were not studied in cancer patients. And fatty liver makes surgical interventions more challenging. When the surgeon is suturing liver, when it's fatty, it melts like butter. So this is there's a real need, especially in young adults, to tackle this problem. And we have new tools, but disciplines do not know about these tools. We have the ability to measure portal pressures now endoscopically. So how do all of these apply to modern care, and where do we see the care in 2 or 3 years? That session is for that, so we can have a discussion. Is what is needed from every discipline for us to get these folks who, are 35 and just starting their career, or 25 and just starting their families, but they're hooked with this behemoth of a cancer. How do we get them across a good life?
And it's interesting. You mentioned portal pressures in this, and you and I had a conversation. I think almost 2 years ago, we were at a dinner together, and we were talking about portal pressure measurement. Actually, we were meeting with some of the cook reps to talk about how we're going to incorporate this device into our practices. And we had a couple of hepatologists with us. And I remember you mentioning this observation that you had at City of Hope, where you were getting a lot of patients who had been in chemotherapy for years in the past, and now you're starting to see people with cirrhosis or early onset cirrhosis, or at least advanced fatty liver disease. And I think incorporating these type of tools and discussing them in a committee is like, hey, the oncologist is somebody on chemotherapy for 2 years. Maybe you want to get a baseline portal pressure and get another one so that you can monitor the progress of the effects of it. So I think that's important as well. But in this specific session, so Dr. Singh is a transplant surgeon. Is that correct? Is that what you said?
So he's a hepatobiliary surgeon.
Hepatobiliary.
And he specializes in metastasis resection.
Okay, and then tell me about the other two physicians and what they're.
So Dr. Marwan Faki is one of the most prominent GI oncologists at City of Hope, and he specializes in immunotherapy, and he's trying to figure out how to incorporate immunotherapy earlier on in the disease. As you know, immunotherapy has changed the landscape of cancer, but as of now, the majority of its use is in stage 4. And as I said, in these young adults, uh, some of them present at stage 4, but we also have a need for incorporating immunotherapy earlier. And if chemotherapy is toxic to the liver, could immunotherapy present a different alternative when the impact is starting to become significant on the liver? One of my areas of interest is how to change the tumor microenvironment with ablation. And this is why you see that the last session, Dr. Kessler, who's the head of interventional radiology at City of Hope, he will be talking about ablation. We have a lot of ablation technologies today. So as I said, how do you throw the kitchen sink in an organized way and come up with a good recipe for these folks?
Absolutely. Okay, so that kind of ties up the morning of the first day, and then you have one more session, which I think is actually great, just to have 3 sessions. And that one is session 3, starts just a quarter to 2, and it's called Breaking Boundaries, Pioneering Advances in Rectal Cancer Management. And Dr. Kaiser is going to be the moderator for that. So tell me more about this one.
Yeah, so this is about colorectal cancer and organ preservation. And basically, we all know that when you have rectal cancer and you have surgery, the impact on the quality of life is not optimal. And actually, that applies to most GI cancers. Like if you have thyroid surgery, 2 years later, people can't tell, you can't tell, you're taking a pill, and your quality of life is okay. In the GI tract, that's not the case. Oh no. We call it a GI tract, but it's a really very complicated and coordinated organ that has secretions, that has propulsion, that has digestion, absorption. So altering that alters this harmonic. I mean, the GI tract by itself has more nerves than the spinal cord. So we know when you cut these, things don't work perfectly. And low anterior resection syndrome, which is a disabling condition, still exists in 50% after rectal surgery 15 years later. So this session is how do we leverage the current technologies and the current disciplines to try to preserve the organ, the rectum, in this way, so people have a better quality of life. Because we are curing, we dare now say that we're more patients with cancer. And if you look at the rectal cancer field, because of the quality of life impact, medical oncologists have been on this giant search. How do we preserve the organ and still cure the patient? So they're trying to figure out how do we get rid of surgery? How do we get rid of radiation? And I see the field of endoscopy playing a big role in that in the future. And we put now more patients in complete clinical response, which is you treat them and you can find evidence of cancer afterwards than we've done before. And that has been a huge change in the management of these patients. And this session talks about, who you can observe, who you can avoid surgery, and what are the technologies and techniques available to try to maximize that, and how do you leverage different disciplines to get there.
Okay. That's yeah, that actually that ends your first day actually. That and just 3 sessions, each one's about 2 hours. Sounds like about 15 minutes or so for each lecture. So kind of like bite size, enough that it's enough for you to keep your focus and understand and learn as a learner, but not overwhelming either. It's not like an hour-long lecture on different topics. So it works. And then every session is going to have a panel discussion, which sounds like that would be where a lot of fun happens, where you actually debate.
We have sessions in between that are not listed on there. They're listed in broad. So it's actually, it ends up 5 sessions. But the other sessions are have typically a case presentation,
Okay.
and then it has also demonstration of the technology that is used in the management of the case. So and we also have a nursing and APP session.
Right.
What happens is after we discuss, for example, after session one, the physicians will leave the room and go to the demonstration sessions, and then there will be a nurse and APP panel discussing the previous session and answering questions for nurses and APPs without physician presence. I strongly feel that, as I said, cancer care is a team sport, and the nurses and the APPs are an integral part of us taking care of the patient in an optimal way. And we provide them with a safe space where they don't feel that they're judged for asking a question,
Right.
and they feel empowered to ask a question, and they want to have discussions, without physicians in the room. So we're providing that. We're trying this format. Innovation is not just in the content. Innovation is also in the format. So we're trying this format and see how people react to it. And that's a feedback from prior sessions and prior years that we got from nurses and APPs, that they want uh, a safe space to discuss these without feeling intimidated by physicians.
Absolutely. I mean, APPs are such an important part of everyone's care team models now that, you know, that if we don't teach them, or we don't provide them the opportunities to learn or the ability to ask questions, then I mean, they're a right, or they're a right hand in a lot of situations. A lot of us can't, at least specifically in the endoscopy world, a lot of us can't do some of what we do without having support from really good APPs. And, sure, they learn by working with you, but it's great for them to also hear different opinions and bring ideas to the table so that they can be, um, have input.
100%.
So, yeah, so you have the AP, and then you have some other like non-CMEA satellite symposiums and things like that. I think that one's during the lunch hour, or yeah, it seems like during the lunch hour, and that's, I think, to be decided so far, right? What's going on with that, or is that locked down?
Yeah, it's locked down. They're decided, but they're locked down. I'm a big believer in uh, teaming up with industry. The industry has the same mission as we do. They just come at a different angle. And I believe innovation and the power of collaboration is very powerful to help patients. So we provide a forum for industry to tell us, what's the newest thing on the block for them. And that lunch symposium is specifically for that.
Okay. No, I mean, that's important. I mean, and we'd be amiss to say that most of these courses uh, can't exist without important industry support. So industry is, it's not just getting a pen and feeding your staff and feeding you. It's, they do a lot to help us uh, get information out there. So that's important.
Oh, absolutely.
Yeah. Okay. So day number 2, Sunday, April 6th. It looks like session 4 starts a little later, 8:20. So you've accounted for some Vegas time in there.
I mean, we finished a little early, so we account for Vegas time too.
Yeah. And I think you wanted to mention Saturday night. There's a concert that's going on at the Sphere too, right? I mean, not that the conference is sponsoring that. So please, nobody. I mean, if they could sponsor it, I'm sure they would, so more people would come to the conference. But you guys are just a couple of you guys are going as friends to, which concert was it?
Yeah, the Eagles concert at the Sphere. We're showing our age, but
The Eagles are one of those ones. I mean, they came out when you and I were like, I mean, they came out before you and I were born, I believe. I think.
yeah. So if you're a fan of Hotel California, the Eagles, I've never been to the Sphere, but I hear the concerts out of this world. That's where that's why we're starting a little later, 20 minutes, so you can have extra coffee the following. End up going to the concert.
So the first session on Sunday is moderated by Dr. Vivek Kaul. I believe he's at Rochester, University, not Mayo Rochester, University of Rochester, if I'm not
Yeah,
mistaken.
he's been a great partner for me in trying to spread the world and endoscopic oncology in the MGI world. Yeah.
Yeah, he and you both have been pretty instrumental in cryoablation for esophageal cancer as well as other parts of the GI tract. Yeah. So this one is called Next Gen Dialogues in GI Oncology, Pioneering Digital Frontiers and Equity. And this has 3 sessions. So one of them is by one of the speakers I think you know somewhat well. And so Hannah Farfor, Sarah Enslin, and Gregory Edos. So
Yeah, so
yeah.
the first talk will be about the use of artificial intelligence in communication. Hannah's faculty from ASU, and she is Vital Talk faculty, which is a group of people who study communication and the impact on healthcare. And she has been working more with artificial intelligence, and she will be telling us how to use, for example, ChatGPT in your communication, whether with patients or other physicians and stuff like that. It's a really very interesting and exciting topic. I don't know if you use ChatGPT for communication, but
I use so actually I use a lot of Chat GPT, but I use Doximity GPT, which is powered by Chat GPT. Or I believe it's powered. I shouldn't say that. I don't know that for a fact, but it's very similar. And I use it for writing my appeal letters. When these insurance companies are not supposed to deny your medicines with AI, but they are. And when you call them out on it, they say, "Oh no, it wasn't." But they're definitely using AI, because it doesn't really make sense when you get their letters. So now we're having battle of the bots. So we use AI to write our denial letter, or appeal letters. They write it for the denial, and so on and so forth. I also use it when I'm trying to word emails, and I type them really quickly or dictate them really quickly. I'll throw it in there and say, "Hey, can you clean this up for me?" Also letters of recommendation. I've used it to, I'll write the skeleton. I'll say, "Can you make this better?" So that's kind of how I've communicated with people. I have also used it in a lot of different ways, which I think, and I know we're off topic here, but that's fine. I use it to write patient instructions. And then I will also tell the GPT, my patients speak Spanish only. Please translate this into Spanish at a 6th grade level. And I've actually had Spanish speakers read it and tell me it was correct. And then I've even done it for some of my patients to speak Hindi or Punjabi and had it written in their language and in their script. And then I showed it to my dad. I mean, I could read it at basic level, but my dad or my wife, they'll look at it and they'll say, "Yeah, this makes sense." And I can actually text that, or give it, print it out and give it to the patient. So it's gone a long way. Asian languages like Mandarin and Cantonese, I've used it for that as well. So
yeah, so you're probably a bigger user than the average. Up technology early, but basically we felt that we needed a talk on this topic, and
absolutely, do. I mean, I think it's an important topic, and I'm just a nerd. That's the reason why I help. All right, and then Sarah. Sorry, go ahead.
Hannah gave the communication talk last year. It was actually the most popular talk in the course.
I can believe that. I absolutely believe that. I mean, there's something to be said too about something that's not purely scientific at a conference. Something that's practical, something that you can use on a daily basis. I mean, all of us are, we want to know the science and we want to know that, but every once in a while we want a topic that is kind of important. It's very important, but at the same time, it's not super scientific where we're overwhelmed with statistics and p-values and sensitivity and specificity and things like that. I kind of want to know, how do you talk about this to somebody? So, all right, and then tell me about the session on genetic justice. What is that?
Yeah, so uh, genomic testing, a big part of cancer care and big uh, part of cancer detection and cancer prevention is the future. And the future is almost here today. One of the challenges is many of the research is done in affluent countries, and in affluent populations. So, how do we get that to be applicable to everyone? So you were mentioning, Punjabi. So is a multi-cancer detection test that was developed in Northern America applicable to the Punjabi application with the genetic diversity? So that this session is to discuss that. I don't know that we have the answers there.
Right.
And I don't know that we're going to have the answers in 2 years.
No.
But I think it's important to ask this question. And if you're using it in a population where you think might not be represented in the research, how much applicable is it? And what do you need to know? So that's kind of what that session is about.
Right. And if you don't ask the question, you'll never get the answer, right? So you have to start asking them now, and you'll get the answer eventually. And 2 years, maybe sooner, the way that things are logarithmically growing, especially with AI and influencing everything. So session number 5, we'll be talking about redefining GI cancer management through targeted diagnostics and therapies. And this is run by Dr. Ejaz Khan. And you have 3 sessions here as well. And so in that, one of them is leveraging AI again. That's done by Dr. Yu. And then is it Kasi? We're talking about cDNA's role in shaping the present and future GI cancer treatment, or ctDNA, sorry. And then finally, Dr. Kiel is talking about advanced GI cancer treatment with precision radiotherapy. So anything special about that session or that section that you want to mention?
Very special. So first, Dr. Yu is a researcher from Harvard who will be talking to us about artificial intelligence and pathology. And his lab has been trying to develop algorithms for the last 6 years in Harvard to not only harness the power of diagnostic in pathology, but also the powers of therapeutic. So can you tell from the slide using artificial intelligence this patient is going to respond to this treatment and then not this treatment? And can you tell what the genomic profile is going to be? And you will be amazed as to how much progress has been done.
Right.
And, people ask why a pathologist at an interventional course? Because, as I said, Superman is very strong outside of Krypton. And learning where pathology is using artificial intelligence is very important for the rest of the team, and how it empowers you to be more precise in your treatments. The second session by Dr. Kasi, he's a big researcher in circulating tumor DNA or liquid biopsies. And where is the status of liquid biopsy today in GI malignancies? For example, in colorectal cancer, now circulating tumor DNA has become a standard of care. And when you're treating rectal cancer, for example, and you still have positive circulating tumor DNA, but you can see an evidence of cancer, is that indicative of micrometastases? Is that indicative of local recurrence? Is that indicative that more therapy is needed? All of these questions are still unanswered today, but I can tell you they will be answered in the next few years. And how does that apply? If I'm doing a surveillance endoscopy and circulating tumor DNA is positive, how do I need to change my surveillance? Do I need to be more aggressive in getting biopsies? Do I need to add EUS to it? All of these are questions there that are unanswered. And the third session is about using precision radiation therapy. Radiation therapy, the biggest challenge with radiation is the long-term adverse events on the normal tissue. Radiation is a very powerful tool in the care of cancer patients today. But how do you minimize the adverse events? Again, in the spirit of organ preservation. If you have a rectal cancer or an esophageal cancer, what can you do? Is it high dose local radiation? Is it using photon beam? And how do you leverage that? And this is what this session is about. The same like all our sessions, different disciplines, gather the power from their own disciplines into the multidisciplinary care.
Wow. And then on that day, also Sunday, you're going to also have the same with the APP summaries and the demonstrations as well. and satellite symposium as well. And then your final session for the course, which starts at 1:30 on Sunday, finishes about 3:30, is collaborative precision organ preservation next frontier. It looks like you still don't have a moderator quite yet for that one, or at least it's not listed on the website. But you do have the speakers, and we have, I think, four lectures followed by a panel discussion.
Yeah, absolutely. So the first speaker is from Cleveland Clinic, and he has Emery Gorgon. He has pioneered a technique of combining robotic surgery with ESD.
Oh wow!
Yeah, and
Oh.
yeah, listening to him speak is just wow. And one of the messages that he brings is ESD has much higher resolution than robotics. If you are trying to be very precise, if you can leverage the ability to use tools from robotics and the ability to visualize different layers and stuff like that from ESD, then you are significantly more powerful in being able to get negative margins and at the same time preserving the organ as much as possible. As far as I'm aware, he's the only one who's using this technique. And again, of course, it's about innovation. That's very innovative. Stephen Lin is a researcher in the field of radiation oncology from MD Anderson in Houston. And he will be talking about the role of radiation in organ preservation, especially as it relates to esophageal cancer. Esophageal cancer lags behind colorectal cancer. When you look at colorectal cancer, we have a lot of tools today for organ preservation, so for avoiding surgery. But in esophageal cancer, if you talked about that 2 years ago, it would have been a taboo, just like it was a taboo 15 years ago in rectal cancer. And the tides are changing. In GI ASCO this year, there were many discussions on organ preservation and esophageal cancer, and we're heading in that direction. And he will be telling us about radiation oncology and how that can be leveraged. And then we have Dr. Michael Smith from New York, who will be talking to us about what the endoscopist can do for organ preservation and esophageal cancer. And finally, Neil Sharma, who is a pioneer in resection and pioneer in cancer therapy, will be telling us about what the endoscopist has in their arsenal to help in organ preservation, including almost acting like a surgeon.
Wow. And Neil's also helped you by being a co-course director.
Yeah, Neil is a course director, and he's been instrumental to making sure this course is a success and it continues to grow.
Right. And I don't think we mentioned at the beginning, but obviously with APP sessions, then anybody who's listening to this podcast, any APPs you work with are more than welcome, especially if they work in the oncology world with you. But also fellows. I believe you have you are trying to get some more fellows to attend this, and so I'll let you kind of explain that.
Yeah, I feel that getting involved in the field of endoscopic oncology requires early involvement and early interest. We all, when you learn something in fellowship, it kind of follows you in practice. And so I'm trying, part of my efforts to build this field. So some efforts are through the ASG, some are through fights, some are through this course. I'm also trying to groom fellows to be involved in this field. And so every year we sponsor 2 fellows. If they present cases that are relevant to our the course, we help them, we coach them on presenting.
Okay.
We work with them on the presentation, and we pay their expenses to come to the course, attend, and get educated. And the fellows that we sponsored last year who were so educated, wanted to publish in this area, and they're working on manuscript for that.
Right.
Really grooming someone to become an endoscopic oncologist. Last year, we focused on therapeutic endoscopy fellows, and it's still a big effort of us, but we're opening it to all fellows.
Okay. So okay, so two spots for fellows. So any fellows listening to this podcast, this is an opportunity. So take it. All right. So you basically, to summarize, I mean, we got a really packed 2 days in Vegas, but um, 6 sessions, 6 primary sessions with sounds like 4 breakout type sessions. And those 6 sessions are roughly 2 hours each, with between 3 to 4 speakers and a panel discussion. So not overwhelming, very wide and diverse topic for Laura. A lot to learn. So if anybody listening to this podcast, if you have an interest in endoscopic oncology, or if you're just looking to learn what it is, and maybe you want some exposure to it, maybe you don't want to practice it, but you want exposure, and learn more about it before you make that decision. I mean, this is a great, easy way to do it. And it's at a fun place. I mean, obviously everybody goes to Vegas and there's fun there, but take an extra day off before or after, probably after the course, and enjoy an extra day there. So, um, okay, great. And then, Toufic, anything else you want to say about the course or to the audience?
Yeah, thanks for having me on your podcast, Mike. It's a pleasure to watch your podcast grow and be so informative, so diverse in topics. And I just want to say how grateful I am to be able to have this conversation uh, uh, and present the forum to discuss it. Yeah.
No, it's my pleasure. I mean, it's always fun. Again, this is one of those things like I said, I just started as a hobby. It's more for me as an outlet, and hopefully it helps people along the way. So, with that, I'm gonna just end with my normal kind of 2 or 3 sentences. One being about mental health. Anybody out there, for physicians, it's a stressful world. We deal with complex issues with our patients. We deal with family issues. So I think, there's a lot on all of our plates. And I think if you're struggling, it's best to speak to somebody, and then also support your societies, whether it's ASGE, FIGHT, and this situation, ASCO, etc. So whatever you're involved in, go for that. And Toufic, thank you again. And I'll see you in Vegas.
Yeah, excited to have you joining us, Mike.
All right, man. All right. Thank you so much. Take care. Bye.